Hello friends, this is Dr. Aditya Bhatt and today we'll discuss something about approach with child with coma. So before we begin, I would like to say that all this theory part is taken from the book called as AIIMS protocol in PICU. So let's begin. So firstly, for approach to a child with coma. So firstly, we need to define that what is coma. So coma is a total absence of arousal. Total absence of arousal. Total absence of arousal. All right. So this is the definition of coma. There is always preservation of brainstem reflexes, and as brainstem reflexes are present and reflexes like Dole's eye reflex is present, so we do not consider coma as brain death, but coma may get converted into brain death. Now, as opposed to states of transient unconsciousness such as syncope, concussion, coma must last for at least more than or equal to 1 hour. Then only you can label it as coma, because it might be concussion or it might be syncope. So to rule out all those conditions, you need the coma for at least 1 or more than 1 hour. The next thing is vegetative state. So what is vegetative state? So there is complete unawareness of self. And environment with variable preservation of sleep-wake cycles and eye opening. Sorry, brainstem function. Brainstem function. So there is variable preservation of sleep-wake cycle and brainstem function. Some amount of sleep-wake cycle and brainstem reflexes might be present, and to consider that the vegetative state is permanent, it is deemed permanent only and only after it has lasted for more than or equal to 12 months in traumatic brain injury and more than or equal to 3 months in non-traumatic injury. So this is the basic of vegetative state. And the third one is minimally conscious state. So variable consciousness, with some amount of environmental awareness. So as you can see, from going to coma to minimally conscious state, we go from the worst condition to the best condition that might occur. Obviously, minimally conscious state is not a best state scenario, but in these conditions, it is the best case scenario. And what is brain death? So there is, as you define it, absolute cessation of all brain and brainstem function And these patients are irreversibly comatose. And apneic. So there is irreversible cessation of all brain and brainstem function in brain death. So these are the four definitions of the four basic coma and coma-like things. Now there are coma mimicking states. Coma mimickers. So there are grossly three mimickers. So first one is locked-in syndrome. So in locked-in syndrome, what happens is vertical gaze is preserved. Vertical gaze movement is preserved. So from vertical, what do you remember? That it is the damage to ventral pons. Ventral pons damage. And in this patient, the ascending reticular activity is also preserved. So, as you know, that what does ascending reticular pathway do? Ascending reticular pathway preserves awareness. So the patient is aware of the surrounding, patient can hear things and patient knows everything, but the patient cannot move except the vertical gaze movement of the eyes. The patient cannot move. So it feels like that you are locked in your own body. You cannot move your body is frozen or out of control. You can, the higher functions are preserved, the awareness is preserved, the alertness is preserved. So you know everything, but you cannot do anything. Now, the next condition is the locked-in syndrome can be caused with also severe patients of GBS and other infectious and para-infectious etiology can cause locked-in syndrome. Now, next condition is akinetic mutism, also known as abulia. Now, in abulia, what happens is that there are lesions in portions of frontal lobe. With subcortical involvement. So the tracking movement of the eyes, tracking movement of eyes and awareness is preserved. And patient follows commands. But patient on its own does not move, does not do anything. And there is no will. There is no will in the patient to do anything. So that is also called as akinetic mutism. There is also difficulty in initiation of movement. As you know, the initiation of movement is generally mediated by the basal ganglia. So there is a lesion in subcortical region, including basal ganglia. So there is difficulty in initiation of movements. And in this patient, tone reflexes, postural reflexes, everything is normal. And the third is psychogenic unawareness. So this is a psychiatric term. Psychogenic unresponsiveness. The patient might be in hysteria or severe psychosis. So in that, these condition comes. So we have seen the coma associated terminologies and coma mimickers. So what happens actually in coma? In coma, pathology of coma, there is abnormal reticular activity, ascending reticular activity. So what happens is the patient has abnormal awareness, because the awareness and the awakeness cycles are maintained by the reticular activity. If the reticular activity is abnormal, there is no awareness, there is no awakeness. So that is abnormal in coma. So that is a pathology. Now etiology. So etiology can be grossly divided into three types. First is coma with focal signs. Focal signs include that there is a focal neurological deficit or an abnormality that might lead you to the anatomical location of the brain, and there are focal signs, so you can localize the abnormality. And there are coma without focal signs, so it is a generalized issue. Entire brain is involved without meningeal irritation. And the third is coma without focal signs with meningeal irritation. So first condition is a focal condition and the other two are the generalized conditions. And the other two etiologies, we'll see that what are the three things that cause. So first one is coma with focal signs. So there is a focal neurological deficit in this patient. So there might be intracranial hemorrhage or stroke or brain abscess without encephalitis, meningitis. It might be Todd's paresis. Todd's paresis is seen in. Anyone can please comment down below where is the Todd's paresis seen. If you do not know, I'll tell you. Todd's paresis is seen in focal seizures, post-focal seizures. It is a post-convulsion paresis of a single part of the body. That's also called as Todd's paresis. So these are the common causes, and the last one might be tumors. So these are the localized causes. Now coma without focal signs, without irritation, meningeal irritation. So what this might be, all the metabolic conditions. Metabolic conditions do not usually lead to encephalitis. They are encephalopathies. So they do not have meningeal irritation. They do not have associated brains. They do not have associated meningitis. So first condition is metabolic condition is hypoxic ischemic encephalopathy, HIE, which is a sequelae of perinatal asphyxia. Then all the metabolic conditions and the inborn errors of metabolisms. Inborn errors of metabolism, like all the organic acidopathies or all the glycogen storage disease or all the ammonia cycle disorders, they are included in metabolic disorder. Lysosomal storage disease, mitochondrial disease, all of them are included in these metabolic conditions. Then due to systemic sepsis, severe metabolic acidosis, diabetic ketoacidosis, DKA, drugs and toxins, and infectious disease. Now, some infectious disease do not have any manifestations of encephalitis, rather they are more of encephalopathies like the rickettsia. Rickettsia infection, nearly one of the MCQ asked in rickettsia infection is, rickettsia infection nearly decimated Napoleon Bonaparte's army. Rickettsia causes the rickettsial Rocky Mountain spotted fever or the Lyme disease. So rickettsia usually causes severe brain involvement, and the patient is hazy. Patient has no, disoriented to time, place, and person, and it is usually associated with the rash. Rocky Mountain spotted fever is rash. Then hypertensive encephalopathy and post-migrainous status. Post-migraine state. So these are the common causes of coma without focal signs, without any meningeal irritation, and the third one is coma without focal signs with meningeal irritation. So this is very obvious. The causes are very obvious. It is meningitis, it is encephalitis, and it is subarachnoid hemorrhage. Subarachnoid hemorrhage may have a specific history of thunderclap headache or a sudden onset headache that, which is the worst headache of my life. That is the history in the patient. Now, what do you do in these patients? How do you evaluate this patient, and what do you do? How do you manage the patient? So the first thing you do is stabilize the patient. Airway, breathing, circulation, decontamination. You have to do this. Maintain the airway, intubate. If GCS less than 8, you have to intubate the patient. If the patient has severe convulsions and patient cannot maintain the airway, you have to intubate the patient. If the patient is not breathing, you need to intubate the patient. If the patient has no spontaneous breathing, no spontaneous effort, you have to intubate the patient. Maintain the circulatory system. You can give bolus up to 60 ml per kg in 1 hour, in the first hour, and you have to identify the signs of increased ICP and decontaminate the patient. Now, along with ABCD in this patient, you also have to check two things. Check RBS via the glucose reagent strip God pod, glucose oxidase peroxidase method. You have to do RBS in the patient, and you have to send for electrolytes in these patients. Then if the child is newborn, you have to go TABCD. Temperature is the most common and the first thing that you have to approach in the newborn. And after you have stabilized the patient is stable, the basics have been done, then you have to send for specific investigations that we'll see. What specific investigations you have to send for. But for that, before you send a specific investigation, if you have a very strong suspicion, then you can start empirical treatment. So empirical antibiotics for meningitis are usually ceftriaxone plus minus vancomycin. If you have very high suspicion of MRSA, you have to give vancomycin. If you have no risk factor for Staph aureus, just stick with ceftriaxone. Ceftriaxone is the wide spectrum, and it usually covers the gram-negative bacillus and pneumococcus, which are the most common organisms for meningitis. Now, you can give acyclovir if you are suspecting herpes, but that is from case to case basis. If you have history of temporal lobe epilepsy or a rash of herpes or the specific vesicular history, then only you have to give acyclovir, or else there is no role. Steroids are supremely beneficial in meningitis. Supremely beneficial. If you give them before antibiotics, at least 15 minutes to 1 hour, they are supremely beneficial in preventing the complications of what happens is when you have the patient of meningitis and you give antibiotics, there is release of toxins and there is the killing of the bacteria, which increases intracranial pressure. So initially you might have a paradoxical reaction in which the patient worsens on the antibiotic usage. So that is prevented by steroids. Steroids is only and only given for less than or equal to 48 hours and not more than that. And you do not have to give the continuation dose for steroids because you have only used it for 48 hours. Now, anti-malarials can be suspected if you have a high suspicions of cerebral malaria. If you have DKA, start insulin. If you have increased ICP, start the medications to decrease intracranial pressures. If you have suspicions of organophosphorus poisoning or opioid poisoning, please give appropriate medications that we'll see. And if there is hypertensive emergencies, give antihypertensive to the patient and it will be beneficial to the patient. Now, what do you have to see in the history of the patient? History. So in history, you have to see that if it is sudden onset or gradual onset, recurrent. If it is the first episode, first time, or recurrent. If it is first time, then if it is acute or gradual. So acute onset, sudden onset, if you suspect, then it might be conditions like stroke or meningitis and encephalitis. One of the historical question asked that which meningitis occurs, rapidly within 6 hours, 24 hours, 12 hours. So that answer to that question would be Naegleria fowleri. Naegleria fowleri is an uncommon infection that occurs in pediatric patient and adult patient, but usually in pediatric patient who go in swimming with in a pond which is contaminated with the Naegleria fowleri, and it causes primary amoebic meningoencephalitis. And many of the books have said that the drug of choice for Naegleria fowleri is amphotericin, liposomal amphotericin B. But not recently, but since last 5 years, there have been multiple studies which has shown that miltefosine is a very, very good drug, and it has shown nearly 100% cure rate with patients with Naegleria fowleri infection. So this is some basic about Naegleria fowleri. If it is a gradual onset, then you might suspect that it might be tumor or it might be metabolic. Again, if it is recurrent, you have to suspect metabolic causes and inborn errors of metabolism. Also, if it is acute and first time, you also have to rule out SAH by asking history of severe headaches. And if there is a preceding history of fever, then always rule out meningitis or viral meningoencephalitis. If patient has history of hypercoagulable state, like patient is a nephrotic syndrome patient, or the patient has a history of sickle cell disease, or patient is factor V Leiden mutation, then you have to rule out cerebral venous thrombosis. Cerebral venous thrombosis is seen with sickle cell disease, commonly seen. Or if the patient has coagulation pathway abnormalities, then you can see arterial thrombosis, like factor V Leiden mutation. We have had a patient of factor V Leiden mutation who presented to us with complaint of deep vein thrombosis in the leg, and the patient was accidentally or incidentally diagnosed as factor V Leiden mutation heterozygous. Now, you have to also ask for bleeding conditions or bleeding diathesis, like if the patient has some coagulation pathway disorder or platelet function disorder. Like hemophilia, Bernard-Soulier, Glanzmann's thrombasthenia. So there might be a hemorrhage or there might be ischemic stroke, there might be hemorrhagic stroke, depending upon the history, the condition may go either way. Now on examination, we see the vitals. Now, why are vitals important? Vitals are important because there is something known as Cushing's triad. What is Cushing's triad? It is hypertension plus bradycardia plus there is breathing abnormalities or Biot's breathing. Usually it is Biot's breathing. So this is the Cushing's triad. Now what happens is, to maintain cerebral perfusion pressure, there is increase in the mean arterial pressure, that is MAP. And the MAP in turn causes bradycardia. So that is also known as Cushing's triad. We will see the Cushing's triad and cerebral perfusion pressure in detail in lecture of increase ICP and approach to increase ICP. But right now, please remember that there is Cushing's triad having these three things. And if Cushing's triad is present, you always have to suspect increase intracranial pressure. Usually intracranial pressure is assumed as increased if it is more than 20 centimeter of water, and more than 40 centimeter of water is, the worst case scenario. Now, there are specific types of breathing. As we have seen, Biot's breathing, there is Cheyne-Stokes, there is Biot's, there is ataxic, there is apneustic. Cheyne-Stokes, as you know, is waxing and waning. Like this. It is increasing, decreasing, and again decreasing. So it is waxing and waning. So this is Cheyne-Stokes. Now, Biot's breathing is irregularly irregular. Like atrial fibrillation, you don't know what is going to happen next. You have no idea. It's like this. Something like this. Okay, you get the point. Ataxic breathing is due to damage to the lateral tegmentum of the lower bones. And apneustic breathing, there are episodes of apnea in between the breathing, and which causes carbon dioxide retention and which stimulates the breathing even more. So it is found in lesion of, this is a lesion of lateral pons, and this is the lesion of medulla. Ataxic breathing is, as you know, ataxia. So the lesion of lateral pons causes ataxic breathing. Now, for the level of consciousness, we have the GCS score, as you all might know, but there is also another score that is commonly used in pediatrics. It's called the full outline of unresponsiveness score. Full outline of unresponsiveness. Now, the whole score is not important, but you need to know the four headers under which we divide the full outline of unresponsiveness. One is I response. I'll post this 4 score in the group, in my Telegram group, Simply Pediatrics by Aditya Bhatt. And if you have not followed the group, please follow the group. So I responsiveness, motor response, brainstem reflex, and respiration. And it also accounts in as respiration for if patient is intubated or not. So this is very, very vital in intubated patients, because there we have to, label in T as T, intubated T, because the patient cannot vocalize. Now, next we see our pupillary abnormalities. So abnormal pupils. So small pupil is seen in pontine lesion. Pinpoint pupil is seen in pontine lesion. or opioid usage, narcotic usage. Okay, a small pupil is the one which is less than 2 mm. Mid pupil, mid-size pupil, also known as fixed dilated, is usually the sign of brainstem death or brainstem death, and it may also be seen in mid-brain lesion. Maximally dilated or fully dilated, max dilated, is more than 8 mm. Sorry, here is less than 2 mm. Here more than 8 mm. So this is seen in mesencephalic lesions, or this is seen in drugs and toxins, or third nerve palsy. Third nerve palsy. Please comment down below the causes of third nerve palsy that you might see this. And if there is a unilateral fixed dilated pupil, then the causes will be uncal herniation, unilateral traction of third nerve. So this you have to remember, these are very, very, very common causes. And then there are specific eye movements like ping pong movement of eyeballs or ocular bobbing, which I'll post in the group. That is not very, very, very important, but that might be asked directly as a question. So that is what ocular involvement are. Now motor system involvement, you know, to decorticate and decerebrate. Above red nucleus, also known as supratentorial, and this is below, infratentorial. Now what happens in what? Decorticate. Decorticate is flexion upper limb, extension lower limb, while decerebrate is extensor upper limb, extensor lower limb. So entire body is extended. So obviously, as you might understand, that decorticate is the initial, and later it becomes decerebrate. Decerebrate has worse prognosis compared to decorticate. Then there might be generalized flaccidity in the body or generalized looseness. So this suggests abnormality in pontomedullary junction, where the pyramidal tract is there. So when the pyramidal tract is absent, you do not have any muscle tone. Now spontaneous myoclonus. Myoclonus usually occurs when we are very close to sleep physiologically. What happens is the body is reminded by the brain sends an impulse. If when the body is sleeping, the brain feels that the entire body is dying, so that it sends a pulse, which leads to a spontaneous myoclonus, jerk-like movement. It is absolute jerk-like movement. So spontaneous generalized myoclonus. See, myoclonus is always localized, and it is always seen close to sleep when the child or the adult needs to sleep. If it occurs in any of the other condition, if it is generalized, if it does not occur close to sleep, then it is always abnormal, and it suggests very, very, very worse prognosis. And myoclonus is also a hallmark of an infection called as SSP, subacute sclerosing panencephalitis, that occurs after the measles infection. Please comment down below the treatment of choice for SSP and what are the EEG findings in SSP. So spontaneous generalized myoclonus is a sign of anoxic brain injury or hypoxic brain injury or generalized encephalopathy. Now, there are multiple herniation syndromes that also we'll see in the lecture of increased ICP. So there are herniation syndromes Uncal herniation, transtonsorial, lateral transtonsorial, foraminal, that we'll see in the lecture of ICP. Now let's go to investigations. So for investigations, we have seen the basic investigation. NCCT is recommended as an emergency measure because it takes only seconds and it identifies brain occupying lesion. You might need MRI brain with contrast for patients having meningitis to see the meningeal enhancement. Now the second line investigation also includes EEG. EEG may there are delta waves. If you see delta waves in awake individual, it is always hepatic encaph. Rademacher's complex are what you see in SSP. And the drug of choice for SSP is inosine pranobex. This is the MCQ. Please remember, isoprenosine or inosine pranobex, it is the same drug. So that is the. Then urine toxicology. If you have suspected intoxication, urine toxicology for narcotics or opioids, you might see, and you might send a heel prick Guthrie for IEM or for ammonia cycle abnormalities or organic acidurias. So heel prick Guthrie you might send for these patients, and along with that you might estimate ammonia lactate urine for reducing substance and urine GCMS, and this is by the method of TMS, tandem mass spectrometry. That is it compares the mass of the materials, and spectroscope gives you different materials which are present. Now for management or the treatment stabilize the patient and specific treatment. Stabilize and give specific treatment. As you know, if you have DKA, give insulin. If you have hypoglycemia, give D10 bolus. For pediatric, we give 5 ml per kg. For newborn, we give 2 ml per kg. You always give D10. D25 is not preferred in pediatric patient. Manage hypothermia. Give antibiotics. If you suspect that there is opioids or confirmed opioids, give naloxone. Naloxone dose is 0.1 mg per kg. Steroids, as I told you, are absolutely beneficial. Even the patient might be in Addisonian crisis. Steroids are life-saving for these patients. So these are the treatment that you have to give for the patient. And if required, please go for surgical intervention in cases of hemorrhage and decrease ICP drugs. That's all for today, guys. I hope you like the video, and if you like the video, please give it a thumbs up, and please like, share and subscribe to the channel. It means a lot. Thank you so much.